I would like to start by introducing myself and my co-presenters. My name is Suzanne Gaudreault. I work with the URC USAID Healthcare Improvement Project. And I'm here with Kedar, who's going to be speaking after me. He works with the Institute for Healthcare Improvement. And Godfrey, Kayita, works for the Ministry of Health of Uganda in the National STD and AIDS Control Program. And the final speaker will be Humphrey Magere. He is our Chief of Party for the URC USAID Healthcare Improvement Project in Uganda. So many of you are probably familiar with the chronic care model. It's been widely used by IHI for about the last 15 years, mostly in high-resource settings. As a model for health system redesign. There's a growing body of evidence around it, and it's really been used with a lot of success in the United States and other high-income countries. Today we're going to talk about an effort to apply this model in a low-income country, which is Uganda. So I'm going to just start by explaining the need for better chronic care health systems in low-resource settings, and by describing the chronic care model itself. And then Kedar will talk about the chronic care model and how chronic care health system needs to change at the national level. And then Godfrey will talk about give some background on Uganda and talk about a chronic care redesign meeting that was held in Uganda in May and June of last year. And then finally, Humphrey will describe the work that we've recently launched in Uganda to prototype a health system redesign based on the chronic care model. So, historically, the global health agenda has really focused on diseases that are unique to, or diseases that are uniquely problematic to low-resource settings, tropical diseases, malaria, and that sort of thing. This was all prior to PEPFAR. So with the advent of PEPFAR, suddenly a huge amount of funding and resources and effort has been put into a chronic illness, an illness that links high-income and low-income countries, and that illness, of course, is HIV/AIDS. And so historically, where health systems in low-resource countries have been very much designed for treating acute illnesses, now we have the opportunity to develop a good model with HIV/AIDS for treating chronic illnesses, and this is already underway to some degree, and we're hoping to work toward improving that model for chronic care of HIV, and with the ultimate goal of being able to use this experience and lessons learned to enhance the health system to address other chronic illnesses. And just so you know, the kind of chronic diseases that are the main causes of death in high-income countries are also becoming the main causes of death in low-resource settings. Already, most of the main causes of death in middle-income and low-income countries are chronic illnesses, and ultimately, pretty much all the major causes of death will be chronic illnesses. So this is a table that describes a little bit about the difference between acute care and chronic care. And many of you are already probably aware of a lot of these points, but basically an acute illness is a single event that you go into your health facility with an illness, you get treatment, you maybe take it for a few days or less, and then you're cured. Whereas a chronic illness is a long-term disease that you have to manage on a daily basis, and often take medicine for on a daily basis, change your lifestyle. There are a lot of health system issues that go along with that go along with supporting a chronic illness. And for this reason, health systems that have been really designed around acute illnesses are not well suited for chronic diseases. And it's certainly the case in high-income countries that a lot of health systems, health facilities are oriented around acute illnesses. And this is why there has been so much work on redesigning them for chronic care. But it's even more the situation in low-resource health systems where even just basic things like longitudinal records just don't even exist. A patient with diabetes comes in and is treated like a new acute patient every single visit, that sort of thing. So treating chronic illnesses in a system like that results in poor outcomes and all of the consequences that go along with that. And again, for this reason, there really needs to be a lot more work on developing the health systems to address chronic illnesses. So this is an adaptation of the chronic care model as it was originally designed by the McCall Institute in Seattle, Washington, in the United States, a group led by Ed Wagner. About 15 years ago, they started doing some research on what elements of system redesign, what elements of quality improvement really lead to measurable outcomes, clinical outcomes improvements. And they found that there were 4 components of health system design that really, when facilities worked on these components, there's a lot of evidence that significant improvements are made. And those 4 areas are in the yellow boxes, basically self-management support, the design of the healthcare delivery system, decision support methods and resources, and the clinical information system, so like documentation. And then to support that, community resources and policies and the larger health systems also have to be sort of redesigned to support chronic care. And in redesigning all these areas, we hope to achieve a patient that is informed and activated, basically able to self-manage their illness on a daily basis, able to communicate with the health system, and a provider team, a healthcare facility team that's very proactive and patient-centered. So I'm going to talk about each of the components briefly, one by one. I'm going to start with self-management because really the chronic care model kind of hinges on self-management. This is a definition of self-management, but self-management is so important because most of the management of a chronic illness takes place in the home by the patient. It doesn't take place at the facility. This is only the facility visit lasts only a few minutes, and some decisions are made by the providers. Maybe some education is provided, but the day-to-day decisions, the day-to-day actions that a patient takes, really take place on the patient's time in the home. And therefore, self-management support is very, very important. How do you help the patient self-manage? How do you empower the patient? That is what's really important with regard to self-management. So what is an empowered patient? What does an empowered patient do to self-manage their illness? It's a little differently. So first of all, they learn about their disease. They learn everything they can. And but self-management support isn't actually just about the patient learning or teaching the patient. It's about helping the patient communicate effectively with their providers, and also helping the patient make decisions about health-enhancing behaviors and using community support structures. It's also about helping the patient deal with the psychological consequences of their illness and the socioeconomic consequences of their illness. So basically, we can say there are 7 basic management of support for self-management, patient self-management. It's not, a lot of people think it's just about patient education, and that is certainly an important part, but it also includes helping the patient actively participate in their care, teaching them skills that are specific to their illness, and then helping them negotiate actions and behavioral changes that will help them achieve the best health possible, and also helping them problem solve, teaching them problem solving skills. Again, addressing the emotional impact that is invariably present with any chronic illness, but in certain illnesses like with HIV/AIDS, there are issues like stigma that make the emotional impact even worse. And then finally, it's important to help patients utilize the community resources that are available, to know about them and know how to use them. And so ultimately, self-management support, again, hopefully leads to informed, activated patients that have productive interactions with their healthcare team. And this has been described as a continuous healing relationship between the patients and the providers. So another component of the chronic care model is community. And the community helps the patient self-manage and also does a number of other things to support good chronic care. In low-income countries, there are a lot of community support structures. Depending on the country and the culture, there are various types of community groups. There are also structures like village health teams in countries like Uganda. Support groups are very common, and community-based organizations, faith-based organizations, all of these can be used to support chronic illness care and self-management of chronic illness. Community groups can also help to lobby for better policies and better structures at the higher level to support chronic care. So another facility level component of the chronic care model is the design of the delivery system. And this involves role definition for healthcare workers. In low-income countries, there's a lot of talk about task shifting, developing new cadres of workers such as peer supporters, using expert patients, people that have the disease, to help other patients, to use their own experience in self-managing, to teach other patients how to self-manage, and to help them learn to problem solve and better achieve good clinical outcomes. Other things that are being introduced in low-resource settings are triage systems. Many countries have well-developed home-based care systems, and these can be used to improve chronic care. So decision support is another aspect of chronic care that's important. Often it's helpful to have evidence-based guidelines embedded in the documentation. So as the provider is filling out documentation, there are reminders. They're filling out a form that reminds them about what needs to be done at each visit. There are also other things like national guidelines that should be available in every health facility, and job aids. This is a photograph of some job aids. Some of them are handwritten, that are posted on the wall to help providers remember what to do, how to help providers make evidence-based clinical decisions to help their patients. And finally, the clinical information system, the medical records, the documentation, and data management systems have a huge effect on how well chronic care is done, and efforts to improve these clinical information systems can have a huge impact on chronic illness care. In low resource settings, a lot of times it starts just simply with a longitudinal record. Most chronic illnesses are still just sort of entered in a registry one time and treated like an acute illness. And like a patient with diabetes comes in and it's like they've never been seen before. They're just an acute patient every time they come in. But establishing a longitudinal record is important. It's something very basic in high resource settings, but this is the place to start for chronic illness care. And other things that help in clinical information systems are disease-specific registries to help address problems of certain populations of patients. So with that, I'm going to turn the microphone over to Kedar, who's going to talk about the chronic care at the national level and a chronic care model at the national level.
Thank you very much, Suzanne. I just sitting in that first row, you feel like you're in the first row of a movie theater, sort of with a big crick in your neck. So that's quite nice. I was just joking with a colleague as I was on my way over here that this conference, although it's named sort of Better Health, Low Cost, and Better Quality Care, should actually be named So Much to Learn in So Little Time, because there's so many different choices that you have in front of you. So thank you very much for choosing to come to this session and spending some time with us learning about chronic care and what's happening in Uganda. I'm going to do something, building on what Suzanne has done here, I'm going to do something taking us from what happens at a microsystem level in a clinical context and actually trying to answer the question of what we would need to do at a national context. What would countries have to do actually to encourage chronic disease management, chronic care at a country level? So that's okay. So there's a couple of sort of key points that I would like to sort of to make to all of you here and to see if we all collectively agree on. And that's that all systems at the moment, anywhere in the world, rich or poor country alike, all systems are providing both a combination of acute and chronic care to patients at the moment. And Suzanne very nicely actually went through sort of what are some of the differences between an acute care system and a chronic disease management system that would be needed. There are a couple key points that I want to pull out of this. And the first is around the premiums that you place on different things, the value that you place on different things if you're in an acute care context versus if you're in a chronic care context. In an acute care system or an acute care context, there's a premium on time. The problem is there's an acute problem, and you need to sort it out, make a diagnosis quickly, and arrive at a treatment plan very quickly and deliver it usually in a very timely and rapid process. That process may or may not involve patient choices and decisions, depending on the situation. The patient that Atul Gawande was talking about in a car accident this morning, those of you that got to see that session, that patient may or may not have been conscious during the care that he was receiving in the trauma bay of the emergency room that he was getting care. That's a very provider-driven care management system. There's a premium on time, rapid diagnosis, getting people in and out of CT scanners or rapid diagnostic techniques, and the providers really drive that care in essence. Chronic disease management or chronic care is a very different sort of situation. There's a premium here, I believe, and I think a lot of people argue, and Wagner certainly did, on partnership and making providers and patients work together in a patient-driven and provider-supported environment. So that's the first sort of general point I want to make about how you design for chronic care at a national level. The second point is that almost all systems that I've encountered, and I'd be interested in others' experiences during the discussion in the room, most systems that I've encountered start with acute care management systems. Most systems have at their origin an emergency response mechanism. In fact, in the US, a lot of the CDC began in essence as an emergency response mechanism to malaria. We started often in the emergency response mode, acute disease management mode, and then transition over time towards chronic disease management. And the final point here is that this is not a Ugandan problem, this is not an African problem, this is not a developing country problem, but rather that this is the transition between acute and chronic disease management really is a universal and global problem. And I just want to make sure I make that point here at the beginning of this discussion. So how did we actually, when we asked the question of how should we design chronic care for countries, how should countries design chronic care systems in their countries, what do we turn to in some sense for guidance? That's the next set of slides here. The first thing we did was review existing frameworks. So one of the things that Suzanne described, and we spent several calls, there's many people in the room that were on those calls actually, before we even went to Uganda, looking at different frameworks and models that are out there for how to think about chronic care at a national or even regional level. The first model that is in the top right corner of that slide here is the one that Suzanne already showed us. That's the chronic care model from Ed Wagner and colleagues at the McCall Institute. This model was really aimed at trying to help microsystems, clinics, the individual patient-provider encounter better. How do we transform that encounter at the microsystem level to make it into a more chronic care, to encourage chronic care or chronic disease management in that individual encounter? The bottom left corner is a systems framework that WHO put out. The WHO Health System Strengthening Framework in 2009 suggested that there were 6 sort of key building blocks: service delivery, health workforce, information systems, medical products, vaccines, technology, supply chain, financing, as well as leadership and governance. And that those would converge on a set of outcomes, including responsiveness as a system, improved health, both levels of healthcare and equity, as well as social and financial risk protection and improved efficiency. So that was the WHO Health Systems framework, and they saw quality, safety, a lot of the things that we talk about as themes in this conference, as actually sort of the vehicle to get from the building blocks towards the outcomes that are on the right. And the bottom right corner was what WHO then did. In 2002, WHO convened a group of experts, to take the chronic care microsystem model, the one in the upper right corner, and adapt it for what countries would need to do to transition their acute care disease management systems to chronic disease management systems. And they arrived at this sort of bottom right green diagram there. And that was in 2002. And that put policy, creating a positive policy environment at the top of the list. And there are several sub-bullets about what you might do there. And it organized the division there into community and created links between community and the healthcare organization. And put patients and families, community systems, and healthcare team kind of in the middle of this triangle. Interestingly, when we went to review the literature around these 3 different frameworks and models, there's a tremendous amount of evidence in literature around the chronic care model, the one on the upper right from Ed Wagner. Okay, there's very little evidence about the chronic care framework that WHO put out in 2002 to guide countries towards changing health systems. Very, very little literature on that point, the bottom right green one. And there's the WHO Health Systems Framework is just emerging and evolving here, and there's some evidence to support that using that to guide how you design your health system may be a useful strategy. So what we did actually in trying to design a method or approach to approaching the problems of the health system more generally is combine the Wagner model, which is significantly evidence-based, with the WHO Health Systems Strengthening Framework, which I'll show you here. Oh, sorry about that. I've already told you. So here's what we did. We took the 6 building blocks that WHO had laid out and the 5 major domains of the Ed Wagner model: self-management, delivery system design, clinical information, decision support, and community resources and policies. And we built a matrix between these 2, and I'll show it to you here. I don't mean to go into this in any great detail, but these were the macro level change ideas that we distilled out of this process that governments could take and chart a path to actually creating chronic disease management systems at a national level. And I'm going to take you through a couple different examples. But if you look here on the upper, sort of across the rows at the top here, these are the domains of the chronic care model: self-management support, decision support, delivery system design, information systems, and community resources and policies. And we took that and we crossed that with the WHO Health System Strengthening building blocks: the human resources, IT, financing for purchasing, supply chain, and leadership and governance. And within each of these sort of boxes, we found elements that governments, nations, decision makers, policy makers could make to actually encourage a system. What would you do to change human resources, for example, for self-management support? What would you do to information technology systems at a national level or regional level to actually encourage self-management support, et cetera, et cetera? Let me take you through 2 examples, and then we'll get to what happened in Uganda. The first example here is what changes you would need to make to your health service. So just going back for a second, what I'm going to take you through is 2 tours of this, this matrix. The first is going sort of down the list. So we'll start with a domain here of the chronic care model around self-management support and show you the change ideas that we had talked about for what a country would need to do in the health system's strengthening building blocks. And that's here. So this is what a country would need to do, or a national level system would need to do, we believe, in order for you to transform that system to allow self-management support to happen at facilities throughout a country. Across the 6 building blocks of the WHO Health System Strengthening Framework, we suggested that you would need to make human resources available whose responsibility or main responsibility or priority was the ability to do self-management support with a cadre of patients. Whether that was actually taking an existing cadre of staff and retraining them, or creating a new cadre of staff, for example, relying on expert patients to enable this self-management support, was neither here nor there. We didn't prefer either way, but some mechanism of creating human resource capacity to actually do self-management support was essential. I'm not going to take you through each bullet point because that will take us the rest of the afternoon, but I'm going to just show you a couple of sort of high-level changes that we had thought about. With regards to information technology, we suggested that self-management support would require data on self-management that would be preserved in the patient longitudinal record that Suzanne was mentioning earlier, that both at a microsystem level as well as in the district health information systems that countries use to assess the performance of the system. For finance, health systems would need to create payment reforms, insurance schemes that would need to encourage, in essence, self-management support practice and the use of that as a way of rewarding either providers or suppliers of services. Supply chain obviously would require self-management support supplies, pill boxes, diaries, etc., that would actually enable patients to keep track of how they were managing their chronic conditions. And leadership would require recognition by professional organizations or bodies that self-management support was actually an important thing that patients and families should be, that the health system should embrace and do. If instead, going back to that matrix, we looked across a domain, looked at a health systems strengthening, one of the WHO Health System Strengthening Framework components. So for example, human resources for health. And then we said, what would you need to convert or do to the health workforce in order to enable it to deliver better chronic care? You could take this view. And in this view, you say, here are the chronic care domains. This is what you would need to do to health workforce, for example, in order to support chronic care delivery at a national level. I don't need to necessarily take you through all this. It's up there on the board. But the point of this, and we can certainly make the matrix and so on available, is that this was just a mechanism of us trying to organize how countries could approach chronic disease management and generate the types of policies that would be needed for them to actually engage in this new and important struggle. So the summary here is that I think all countries are battling this transition, as I started in the beginning, saying that both rich and poor countries alike are battling this transition between acute and chronic disease management. And the acute side being focused primarily on diagnosis, rapid treatment, and output-driven systems towards chronic management systems that involved outcomes, a focus on outcomes, and a focus on longitudinal management of patients. Broad coalitions will be necessary in order for us to do this. It's not simply about ministries of health, but rather, if we're trying to actually reorganize payment, for example, you have to start tackling ministries of finance and how we actually reward and incentivize chronic care management for a country. So it's not sufficient for us to remain within healthcare as the only domain here. And I'd get to this. The model that we presented, the idea that we presented, the models that we looked through, the Wagner model, the WHO Health System Strengthening Framework, the WHO Chronic Care Diseases Framework, is they're all wrong. And even the one that we presented here, the matrix that I presented a moment ago, I'm assuming, or I make the assumption, that that model is wrong. The idea, though, is that some of these models might be somewhat useful for countries to actually make some decisions about. I'd say I'd conclude here with this final point, which is that all of these models and all these ideas need formal testing and prototyping. And in fact, I think that's what we're about to learn more about, how Uganda actually did some of that work. So let me invite, I'm not sure who's, Godfrey, are you going next? So I'm going to invite Godfrey to come talk to us about what happened in Uganda.
Good afternoon, colleagues. Kayita Godfrey, Program Officer at the Ministry of Health in Uganda. I'll be taking you through the challenges that of providing chronic care and experience for Uganda. Uganda is a country in Africa, bordered within the eastern part of Africa, bordered by Sudan in the north, Kenya in the east, Tanzania and Rwanda in the south, then Congo, DRC Congo to the west. Uganda has a population of about 32 million people, with a growth rate of about 2.7%. Our per capita stands at $490. We have a health spending of about $12, $3 less than the Abuja Declaration for the African nations. The life expectancy stands at 52 years. We have about 1.2 million people living with HIV/AIDS in the country, and of those, about 100,000 are children. The HIV prevalence was high some time back, about some 10 years ago, and has been brought down to 6.4, where it has stagnated for some time, but this is about 5 years data. We are currently doing our serobehavioral survey to understand what the current prevalence is for the country. So I think for the next meeting, if we have an opportunity to present, we'll be giving you the most recent figures. TB/HIV is a common problem in the country, and these are moving together and give a background to HIV/AIDS care in the country. The struggle for HIV in Uganda started quite early from the 80s. Within around 92, we started providing ART, and this was in research and a bit of private settings. In around 2003, we started the public health approach to HIV care. And at around that time, we trained our health providers using the WHO-based guidelines on integrated management of adult illnesses and child illnesses for both the adult and pediatric care. We also brought on board the integrated management of pregnancy and childbirth for the pregnancy-related issues. And all this gave us comprehensive management for HIV, looking at HIV as a chronic disease with a background of ART as the driver to HIV moving from acute to chronic. Now, apart from HIV and TB has been around for quite some years in the country. So TB and HIV are some of the diseases that we have really managed as chronic diseases. Many of the true chronic diseases care is limited to regional referral hospitals and a few general hospitals. These are looking at sickle cell, diabetes, hypertension, cardiac diseases. So healthcare training in the country for all the health professionals, nurses, doctors, allied health has remained so much focused on infectious and parasitic diseases in the country. So almost a year ago, in May, in Uganda, we brought together a couple of professionals from across the various continents in the country, and we looked at chronic care, looking at many of the models that exist that my colleague Kedar has been mentioning previously. So we came together with 3 objectives in Kampala. One was to identify elements of the chronic care model that is applicable. Uganda being a study country, looking at low or limited resource country, we are trying to look at the approaches that can be developed and integrated within a prototype district, because Uganda operates a decentralized health system that looks at the national level, regional, non-administrative, district, health sub-district, and then the village level. We also looked at the recommendations that we could make to the Ministry of Health as regards chronic care. We came up with 5 recommendations that we looked at, and moving forward, my colleague Humphrey will be mentioning what efforts we are doing in the country. We are looking at committing the Ministry of Health to have a health systems redesign that would look at chronic diseases, keeping in mind that we also have quite a big burden on acute illnesses in the country. We are looking at how resources can be prioritized, human, material, to cater for this. We are looking at how we can get everyone committing to the chronic care model in the country. The second, we developed a model for chronic care, very much what Kedar presented as the last piece on that. And we are trying to see how we can demonstrate the use of quality improvement or improvement science in improving the care provided to the people living with HIV/AIDS. The other recommendation was to strengthen and support existing health systems. Like I earlier mentioned, at village level, here we have no infrastructure. Teams come together in a community and look at the health of a village. At that level, we have the village health teams that come together and look at this. So we are looking at that system to see how it can be strengthened. At health facility level, we have expert patients. This is a science that we again brought from the WHO training models, where we have clients that are experts on their illnesses participating in training of healthcare providers, but they do carry these efforts forward in looking at the care they provide. They work with health teams at health facilities in providing care. At health facility level, we have health unit management committees. These bring on board some clients' representations, some representations from the community, and health workers come together and look at how health is being delivered at a facility level. The other is we are looking at healthcare and patient and community support that comes into play as you provide care in a health setting. We are looking at health facilities really working in teams, again borrowing from the improvement science so that teams help to improve better than individuals. We are looking at how communities can be educated and they come on board to begin looking more critical about the health, the chronic, or the health and the chronic care that they receive. We are looking at health education and schools really to sustain the chronic care curriculum, taking it pre-service and the rest of the other levels to support that. The other recommendation we had was on health systems. Much of the health management information systems that exist in our countries is pretty much on acute. You have a form document written out. As you get care and move out of the facility, sometimes you move with your documents and no documentation remains at facilities. Chronic care, we are looking at how we can be able to establish longitudinal records that are kept at facilities, and one can always make reference to them as they provide care for these clients. That would give the providers an opportunity to look at more critical on health outcomes and the care they are providing to their clients. And also look back to generate some data that would be useful for them to keep improving in their care. So much of that are the issues that we looked at as the 5 recommendations that we will do in moving forward with the chronic care. I would invite my colleague Humphrey to take us through the work that the country has been able to do to date as regards this. Thank you very much. There's a copy of the report. We have some few copies here. Some of you could have.
Okay, thank you very much, Godfrey. After the conference in Kampala, it was decided that we try this model in one of the districts in the country. And we agreed together with the Ministry of Health to focus this effort in one district in Uganda. And this district had 15 health facilities, 5 hospitals, and 10 health center 3s. These are health facilities which are lower than the hospitals. And we did a baseline survey to find out where we are in as far as managing chronic illnesses is concerned in the country. This baseline looked at the various elements of managing chronic care, and one of them was patient self-management. When we looked at self-management and we're looking at high blood pressure, we're looking at diabetes, HIV, and TB. That graph shows you issues to do with patients knowing the drugs that they are using, patients knowing how long their treatment will take, patients being aware of the side effects of the drugs that they are using, and the kind of support that they could be getting from their family and the communities, and if there's any support they could be getting from the health facilities. And we found out that TB and HIV was relatively well catered for in the area of self-management. Patients knew the drugs they were using. Some of them knew that is a lifelong disease, especially for HIV, and they are relatively aware of the side effects. And they were able to say that they can get support from the health facility and from the family if they get any problem. We also looked at the self-management still, and in some of the patients had some issues to say. One patient said that patients with HIV and TB have special days and special health workers. They have dedicated staff for that. Then he said, for me, when I come, I line up for long with other patients, and I don't get time to discuss my problems. I just get drugs and go home. I want to know why I get injections and not tablets like HIV patients. This was a diabetic patient who comes, gets the drugs, and just goes home without knowing why she's getting this treatment and not another type of drug. A health worker said, we see HIV patients every month, but patients with diabetes come when they are sick. If they are not sick, they don't come. They are managed as if they are patients with acute illnesses. We also looked at tools for monitoring the patients, and we found that in HIV and TB, we have tools for managing patients. We have longitudinal patient records, but we didn't have this in all the 15 facilities that we visited. There's nothing for diabetes. There are no monitoring tools for high blood pressure. We also looked at the availability of mechanisms to support good clinical decisions. Things like guidelines, standard operating procedures, use of reminders, and access to specialist attention. And in this, we found that TB and HIV were doing relatively better. There were no such things, no guidelines, no standard operating procedures, and no use of reminders for diabetes and high blood pressure. Okay. So after doing the baseline, we worked with the district to carry out the first improvement collaborative learning session and to introduce the chronic care model. Following that, we did a first coaching visit where we trained teams which comprised of Ministry of Health, the district health teams, and members of the Healthcare Improvement Project. We also did, basing on the baseline information that we had, we provided some basic logistics for recording the patient's names and data, and also provide box files to help in improving records management. In one of the facilities, they had improvised a diabetic medical record form, and we thought this was a very good record, and we expanded this to the rest of the health facilities. Yeah. So some of the things that were introduced during the learning sessions and the coaching visits was self-management to improve the knowledge of the patients on their illnesses, to improve the skills of the patients in setting their own goals and making sure that they adhere to treatment, and work on the motivation of patients so that they're able to participate in the clinical activities and in taking their drugs. Another thing that we worked with the facilities was to improve on the delivery system design. All the sites drew the flow charts to be able to manage their patients better, and some of the sites assigned staff specifically for supporting the patients on self-management. And in some facilities, they made some changes in how patients are seated when they come to the facility. Instead of mixing patients who have high blood pressure, HIV, and TB in the same sitting area, they rearranged them so that they are able to sit separated and get services better and faster. On clinical information system, sites introduced diabetes and hypertension registers where they didn't have. In one of the facilities, they introduced longitudinal files for diabetic patients, and in another facility, they provided exercise books to the patients for recording the treatment that they are being given. And on decision support, most of the facilities developed their own simple documents which they could put on the walls to remind the patients on the services that are available and what they can do, and even the days when they can come for the services. Some of the other changes that they suggested to do was to form chronic care quality improvement teams in the facility so they're able to meet regularly and discuss patients together with the health workers on what services are available and what they can do to improve their facility services. In some of the facilities where they were charging fees for these services, especially for diabetes and high blood pressure, the health workers together with the staff and the patients agreed that they could reduce or even eliminate the use of user fees in those facilities. Initially, when we set out to do this, we were really focusing on HIV to see how we can improve the management of HIV as a chronic illness. But the staff in the facilities that we went to work in and the patients felt that it was very important for using the same procedures to improve management of other chronic illnesses like diabetes and high blood pressure. And initially, they want to look at all the aspects of chronic care, delivery system, information management, decision support. But we thought that was going to be a lot of work to do at the beginning, and we wanted to refocus their efforts on self-management support, because we think that if we can do this and do it well, then the other elements of chronic care management will also fall in place. We are looking forward to a second learning session that will be used to share the experiences that all these people have had, and then we see how we can move forward on improving chronic care in Uganda. Thank you very much.